Good afternoon, members of the press. My name is Kelly Atlee, and I represent communications for Foundation Health Partners. Thank you for joining us for today's press conference, and thank you for the great work you do in keeping your communities informed. As you know, Foundation Health Partners recently activated crisis standards of care. This topic, as well as Foundation Health Partners' COVID-19 vaccine policy, has generated several questions from you that we want to be able to answer for you today. We have two key speakers lined up to talk to you today. First will be Foundation Health Partners Chief Medical Officer, Dr. Angelique Ramirez, and following her will be Nicole Welch, Chief Human Resource Officer. We'll take your questions at the very end of the presentations, if you can please put them in the chat box. And kicking us off by Zoom is Foundation Health Partners President Jeff Cook. Jeff?
Thank you, Kelly. I want to thank each of you for being here with us today to receive an update on the COVID-19 pandemic status in our community. We are sorry to say that the COVID-19 transmission in our state remains high, and we have the dubious honor of having the highest rate per 100,000 population in the country. Our Fairbanks Memorial Hospital census today is 81 patients. Of those, 29 patients are confirmed to have COVID, making 37% of our inpatients being COVID. COVID patients require a lot of staff, time, and support, and we'll be sharing today with you some of the impacts that means. I want to particularly thank you for telling the story of our healthcare system, the stories of our employees, and the stories of our patients. You have told those stories with compassion, caring, and empathy, and you have reported the facts of the situation and not dealt in hearsay, rumors, or unfounded cures. You have kept the public informed. To Gary Black at the Fairbanks Daily News Monitor, thank you for the editorial in yesterday's paper entitled Crisis Standards of Care, Reaching a Grim Pandemic Milestone. Let's hope that we can soon transfer from grim to hopeful to done with the pandemic. And I might say I'm isolated at Harding Lake by myself, and I usually would wear a mask, and I apologize for not having a mask on, but there's nobody within a couple miles of me today. So with that, we'll pass it on to, I think, Dr. Ramirez.
Thank you, Jeff. So last Friday, Foundation Health Partners enabled crisis standards of care, something that none of us have ever done before. So I'm going to cover three things today in my statement. First, what does that mean? What is that? Second, why we did it and why we did it then. And third, what does this mean if you're a patient here in Fairbanks? I think that's the most important part. So first, what are crisis standards of care? This is not a term that we use very often in American medicine. It usually is used in the context of a natural disaster or on the battlefield, not something we see in everyday life. However, as we've seen here, it can happen in the context of a global pandemic when the healthcare system capacity is severely impacted, as it has been here. Conventional standards of care are what we are all familiar with. That's everyday care. Contingency standards of care are what we have been living like. Well, what we've been living with for the past year. It's where things look different, may happen in different places, may happen in different ways, but it's essentially the same care. When you enter crisis standards of care, it's because there is a scarce resource, triage of how and when to use that resource is required, and the focus transitions from the needs of the individual patient to how best to utilize that scarce resource for the population at whole. How do we best meet the needs of our community? And it's a different approach. So since this is so different, I've been struggling with how to convey this to our staff and our community. The best example that I've been able to come up with thus far is what just recently happened this weekend. We had a major snowstorm, 4 to 9 inches of snow, depending on where you live, over a couple days, and lots of power outages. My best record is somewhere around 4,500 homes impacted. So the scarce resource in that case are the crews who have to put the power back on. They can't be everywhere at once. They can't do every home at the same time. And so they have protocols as to how they do that. It's not necessarily the first person whose power went out. It's not necessarily the first person who's has a refrigerator full of their year's worth of food for the next year and might be impacted the most. It's really, they have protocols. Typically, those protocols are usually first responders, hospitals, assisted living facilities, because those are where vulnerable live, or they protocolize by the outages and how many people are impacted and go to those first. So they are taking a scarce resource and applying it to the community as a whole in terms of how best to meet the needs. This is not something that we had typically done in medicine, and medicine is usually practiced at the individual doctor-patient relationship level in terms of what's the best care for that individual patient. In crisis care, the circumstances are such that the focus transitions on how to deliver the best care for the community as a whole in the setting of a scarce resource. So why did we transition and why now? So the basis for our decision, and it was a challenging decision, was threefold. One is the continuing challenge with our inability to transfer patients to other hospitals, requiring our clinicians in our facility to consistently stretch our skills beyond our routine scope of practice, our routine scope of services. And because we are keeping patients here that we usually don't keep. So that's number one. Number two, the fact that we were at capacity across the organization as a whole this past week, forcing us to make decisions on a routine basis as to how best to utilize our OR time, our inpatient beds, our ICU space. As Jeff mentioned, our current COVID percentage is sitting at 37%. Not quite double our hospital census, but getting there of routine patients. We have COVID patients in our ICU on 2 South, our behavioral health unit, Women's Center, Pediatrics, and NICU. And we are currently treating our youngest COVID patient to date, who's 14 days of age, and our first with pulmonary disease. So our capacity was our second reason. A third reason is the restriction that we had to recently place on the monoclonal antibody. This is a therapeutic treatment that we have found to be very beneficial for our patient population, but because we did not have enough to give to everybody who wanted it and who met the EUA requirements, we had to limit its use to those patients who would most benefit. So those were the three reasons for the transition. So what does this mean for you as a patient if you live here in Fairbanks? So for many of you, care will look no different. You'll see the same doctors, same great staff, all of us, all of them committed to providing high quality care at all times. You may not see a difference. In the case of patients who were previously eligible for the monoclonal antibody, it means you're only able to get it if you're at high risk for serious illness, hospitalization, or death. 2 weeks ago, you would have been able to get it, even if you were at low risk, and we would have recommended it for you because that was the best that we could do for you as an individual patient. In other cases, we may have to defer your procedure or your surgery. In still other cases, we may trial outpatient treatment with close follow-up first to see if that works, rather than moving immediately to an inpatient admission. Alternatively, we may discharge you from the hospital sooner than we usually would with close follow-up. This is not how any of us want to practice, but at this particular point in time, with the number of cases that we have in our community, and with the impact on our hospital capacity, the number of staff beds, the number of staff we have, the resources that we have, this is what's been required. At this point, I'd like to introduce Nicole Welch, our Chief Human Resources Officer.
Thank you, Dr. Ramirez. I'm going to talk a little bit today about the staffing situation. In 2020 and 2021, we have seen unprecedented staffing challenges at Foundation Health Partners. Obviously, we're not alone in that. Many employers in this community and across the country are dealing with similar issues. This challenge is only more magnified by the current COVID crisis we are experiencing and the need for these critical individuals. While we continue to actively recruit and hire, we are very excited to receive the additional emergency resources that the state has contracted to supply. Today, 7 individuals arrived at FHP to begin supporting the care at Foundation Health Partners. We've received 3 medical staff RNs, 2 emergency department RNs, and 2 respiratory therapists. We are expecting 13 other individuals to filter into the organization over the next couple of weeks. In addition, in early September, our FHP Board of Directors voted to require the COVID vaccination for all staff and providers. This was a difficult decision in part because of our current staffing challenges, but our board believed it was the right thing to do to keep our patients and staff safe. The expectation was that all staff and providers would be vaccinated or have a religious or medical exemption by Friday, October 1st. Fortunately, our employees were largely supportive of the policy. By end of day on Friday, all staff had taken appropriate action, including 10 employees who have chosen to leave the organization. While we hate to lose any staff members, we do respect their decision. These individuals were from around the system and a mix of both clinical and non-clinical staff. The remaining employees are all compliant with our current COVID vaccination policy. Doing what we can to take care of the FHP staff and meeting the staffing needs is a number one priority for the FHP leadership team. I'm going to turn it over to Kelly to track questions.
Thank you, Nicole. All right, if anybody has questions, if you can put them in the chat box, please. And we actually have one participant that's showing up as LA Scan 3. I wonder if you wouldn't mind introducing yourself in the chat box for us. All right, and let's see. We will have Dr. Ramirez come up, and I will read the questions. This first question for Dr. Ramirez: do you need to choose who goes to an ICU bed and who doesn't? Can you say more about the process of making those decisions? In other words, are you consulting anyone who is making the decisions, and how many decisions have you had to make so far? Have you had cases yet where that choice resulted in deaths or complications for people who did not receive the bed or were discharged earlier? In addition, what non-emergent surgeries and non-emergent procedures do you postpone or cancel? And I'm sorry, let me tell you who that question was from. That was from Alina Neiden with Fairbanks Daily News Miner.
Okay, so I'm going to have to, can you move it up to the top a little? I'm going to have to take those a little bit one by one. So I'll address how we've been approaching this. So I think at this point in time, we're approaching this phase of the pandemic much like we've approached other phases. And when I say that, I mean we're trying to be very proactive. We're trying to be thoughtful. We want the best outcomes for everybody. We felt the need to put these processes in place at this point in time because there have been situations where we have come very close to having to make that decision, but it did not actually happen for an ICU bed. That happened very recently, but we didn't have to. The processes that we are putting in place are the processes that are common with crisis, best practices for crisis care. Again, we don't have a lot of practice in doing that in the setting of a pandemic. We are borrowing on experiences from elsewhere, but those processes involve twofold. One is we do have a team, a crisis assessment team that made the decision that it was time, and it's based off of roles of medical and nursing clinical leadership. That team has ethics representation on it. That team is reviewing all of our policies to make sure that we are doing them in a fair and equitable manner. And a good example of that is the monoclonal antibody policy and the restriction and how that was made. Second, we are putting in place a process for what's commonly called triage team consultation. So if a frontline clinician is faced with a decision that is not typical that they would have to make, when there's a scarce resource, either OR capacity or ICU bed capacity, that they don't have to make that on their own. And actually, we are not asking them to make that on their own. If there is no protocol to cover it, then we will have what's called a triage officer on call at all times to consult to help make that decision. The background that we are using is the guidelines and the guidance that's been established through the Alaska Allocation of Scarce Resources document and the process that's outlined there. And that's all available on. The high level of that process is available online. What I just spoke to is how we are operationalizing it here. We are very hopeful that as long as we keep ahead of this and looking at the protocols that we need to put in place to deliver the best care for as many people as we possibly can, that we hopefully will have little need for that individual triage consultation. But we want to make sure that we have that available at all times. So then, have you had cases yet where that choice resulted? No, we've not had to make any of those choices at this point in time. What non-emergent surgeries and non-emergent procedures do you postpone or cancel? To date, what we have been doing is in consultation with the surgeon, we've been making those decisions as to which ones we can defer. This process will allow us, if we end up in a situation where we cannot distinguish, then we'll have to go through this process to make that determination.
Thank you, Dr. Ramirez. The next question is for you as well. It's from Morgan Krakow with the Anchorage Daily News. She wants to know if you can detail more about the youngest patient with COVID-19 and what complications they're experiencing.
So we have a now 14-day-old with COVID disease. We have had infants in the past test positive for COVID. But this is the first with pulmonary disease that has required treatment with steroids and the antiviral agents that we usually use on adult patients who have COVID disease. The baby has required oxygen as well, the infant. We do expect and hope that the infant will be discharged soon.
Thank you, Dr. Ramirez. The next one is for you as well. It's from Dan Gross with KUAC. How many of the COVID patients at FMH have arrived at the hospital seeking treatment for virus symptoms versus being there for another issue and testing positive for COVID?
So that's, we do routinely, we test routinely on admission testing, and we also routinely test on pre-procedure testing. So we do identify patients who are not here for COVID disease, but are here because they test positive. On today's census, I can tell you that, as Jeff referenced, we have 29 who are currently testing positive. We have 22 adults who are being treated for COVID pneumonia on our 2 South unit, which includes, it's really kind of an intermediate care unit with some very ill patients. We have, in the ICU, we have 2 who are being treated for COVID disease. And then in pediatrics, we have 1 that I spoke to who's being treated for COVID disease. In addition, I believe we have 1 in our women's center, 1 on peds, and 2 in behavioral health who are in-house right now and they happen to test positive. I will say that even though they're not being treated for COVID, they do require activation of all of our isolation procedures so that we can protect both our staff and, most importantly, any other patients on those units who are currently being treated for other conditions. And so it just adds a layer complexity to our care processes.
Thank you, Dr. Ramirez. The next question will be for Nicole, and it's from Richard Aston with KTVF Channel 11 Gray Television. And he is asking, how long will the FEMA clinical support last, and will more arrive later on?
So the state has formed the contract for 90 days with a possible another 90-day extension. So at this point, it is 90 days. The individual clinicians, however, only sign a contract for 30 days, and then they have the option to continue for another 30 or another 30, which we're obviously trying to welcome them in a way that they're going to want to continue to stay here locally. Waves will continue to come in across the next couple of weeks. I think as we get closer to that 90-day mark, they'll be evaluating the continuation of the need.
Thank you, Nicole. Are there any other questions from any of our press partners? Going once. All right, Dr. Ramirez, anything that you would like to add? Nicole, anything that you would like to add? Okay. Jeff, how about you? Anything that you would like to add? Would you like to close us out?
Well, thank you. And I love Dr. Ramirez's comparison about electricity and the crisis mode. But out at Harding Lake, I'm proud to report we had 20 inches of snow and a power outage for 25 hours. And I just saw 2 plow trucks go by, and the power's on and life is good. So thank you again, all of you, for telling the story, for being so interested, and for helping the public get the facts they need to know about what's going on with COVID-19. You're making a difference. You're helping people make that decision to get vaccinated or to social distance or to mask. So keep it up. Our sincere thanks, and you all have a good day and a good evening. Thank you.
Thank you again, everyone, for your participation. If you have any follow-up questions, please email them to us at publicrelations@foundationhealth.org. Thank you.